take this opportunity to thank the Vietnamese Association of Orthodontists for the kind invitation for me to share my experience of using the Invisalign system for treating our patients. Okay. Just a bit of background on myself, because some of you may not have seen me, or this is your first time, hearing about me. So I'm an orthodontic specialist. I work in Hong Kong. I'm brought up in Hong Kong. I'm not born in Hong Kong, but I'm brought up in Hong Kong. I'm educated there. I graduated in 1985. I worked as a specialist. Since then, I've been in the government of Hong Kong. I worked in the hospital authority, treating cleft lip and palate patients. And since 2013, I've been in private practice. If you ask, and also I've been teaching at the university for some time, teaching the orthodontic students at a part-time basis. And then finally, if you ask me what's my passion is orthodontic biomechanics. How can we move teeth using the appropriate force system instead of using the appropriate shape? We need to use the right force system to move teeth. That is my passion in orthodontics. So today I'm going to share my experience and some cases about how I treat children or growing patients with a clear aligner. I'm just going to show you some cases, how I do the setup, and how I monitor the cases, and we can look at a variety of cases. And because of the time that I've been given, I can only show you some of the cases that I've been able to treat. So we should actually ask ourselves what actually is the problem that we're looking at. In a study in Europe that was done, they looked at 1,975 children from the age of 6 to 8. They found that a quarter of the children had an IOTN of 4 or greater. Okay, so of the 45 to 25% of children that had it, most of them had a deep bite, of over 46%. The others had an overjet, large overjet, and some of them had anterior open bite, cross bite. But that was in Europe. But I think in Asia, we're seeing a different trend, which is I think we're seeing more of cross bites, more reverse bites, because we're looking at a different population profile. Like in Asians, we see more protrusive mandibles, a more maxillary deficiency. So why should we be so concerned about children? Because, if we cannot, I cannot accept to see that there's a problem that will affect the jaw growth and also affect the dental development. So, and also if we look at the American Association, the recommendations that they have, they're recommending that, children be screened at the age of 7 to see if there's any problem. Like if there's a problem, then we should see if we need to have any guidance in guiding to giving them a better jaw growth, or maybe to allow the teeth to develop properly. So what's the benefit of treating children early? Well, we see better smile in our children, because nowadays children, they do go on social media. They see themselves on Facebook. They do IG, TikTok. Everyone is on there. So they see themselves. If you have a pretty space, they're more exposed. So I think children nowadays need to be, have a better smile as well. And then in my locality in Hong Kong, the children need to go for school interviews, because they need to be, they want to go into a good school and they get interviewed. The parents want the child's teeth to look straight. So nowadays, there's a pressure on children to look better. And one of the other benefits that, if we do early treatment, we may simplify or even limit the amount of treatment that we do in phase 2. So there is this argument about phase 1 and phase 2 treatment versus only one phase of treatment. But the way I look at it is that I would rather not deny treatment to children because I may need to do a second phase. Because by limiting or by lessening the severity of a malocclusion in the early stages, I may reduce the complexity of treatment, and also I may avoid treatment in the later stages. Well, am I right to say that? Yes, there are studies to show that there's a reduction in the treatment need from 30% to less than 10%. There's significant reduction in the severity of the cases and in the complexity, and if you don't do anything. So having said all this, so let's look at a case and see how we're going to go about it then. Well, you see cases like this coming into your office. Children in the late mixed dentition, they come in, like parents come in, my child has a crossbite. Or they say the teeth aren't straight. They don't look normal. That's what they're going to tell you. So you look at it, well, you see there's an anterior crossbite, from the front teeth. In the upper arch, you can see there's not enough space, and there's still late mixed dentition. And if you take an X-ray, then it will confirm what you see. You will see that there's quite amount of crowding in the upper arch, and the patient is still in her late mixed dentition. So are you going to wait at this stage, or maybe do something, right? Then you take an X-ray, you see, well, we see a protrusive mandible by the AMB being a bit in class 3. The SMB is also a bit significant. The upper incisors are quite upright. If you look at the upper incisor and SM, the IMB angle shows a retroclined incisors. So what are you going to do then? So what options do you have? Well, you can argue, well, I look at a severe crowding, I'm not going to take out teeth. All right? Do you think of, well, it is crowding, severe crowding? Well, one option is to take out teeth. Well, then you have a second one. What about expansion? Would you think of doing maxillary expansion to gain space? Yes, you could. But if you look at the case carefully, if you look at the case from the frontal, you see that the maxilla and the mandible are more or less, they're not, you don't have a constricted maxilla. So then you will say, if I do an expansion, maybe it will be too much for her. Then you will think, well, is there another option? Well, if you look carefully in the upper arch, you will see there's some spacing on the upper left side where the premolar is coming out, there's some leeway space. Well, and also because the teeth are in crossbite, well, if I procline the teeth forward, I will gain space. So then that's one option that you could consider as a third one. So that's what I did. I wanted to do a therapeutic diagnosis, as Prophet was saying. If you're not sure, don't go and take out teeth. Do a therapeutic diagnosis by treating the case and see how it comes out. So that's what I did. Okay. So what I did was to do a 2x4, but not the ordinary 2x4. If you look very carefully, I put a arch wire, a sectional arch wire on the incisors, upper incisors, and then I had a cantilever, a TMA 017025 cantilever to intrude the incisors and also to tip them forward. This is the type of biomechanics we're talking about, just blindly putting in a 2x4. And then in 2 months' time, it's very quickly, very smoothly, using 80 grams of force, we're able to procline the incisors forward, and at the same time, we intruded the incisors, and then thirdly, we created space for the canines. And then after another month, I put in braces in the upper. Okay, so you can see I'm now opening up the space. I'm starting to think of opening up the space for the canine. And I also have a lingual arch, a horseshoe lingual arch, just to maintain the shape of the transverse form. Because if you put a cantilever at the back without any control of the motor, you will tip them outwards. Because if you've been on Professor Choi's case from Korea, he will tell you birthstone needs to put a lingual arch to hold it. That's what they advocate. So, but the problem is that children or parents, when they see you putting braces, like the child is 7 years old, 8 years old, and you tell them you need braces, metal braces or anything, they will get scared of, because people are very afraid of pain. They're afraid of the wires. They're afraid that it's going to hurt them. They can't come out. They will look ugly. So that is one of the barriers to having dental care. So is there anything that we can do to help to make our patient accept dental treatment? Sorry, go back in. Well, with the advent, now we have clear aligners. I use Invisalign, so I put Invisalign, the name of it. With Invisalign now, they've looked at it, and the acceptance of using a clear aligner is higher, because they looked at it and they found that there was less anxiety with patients knowing that they had to undergo Invisalign treatment. The pain levels were lower, and they had a higher oral health related quality of life. People were more enjoying themselves. They can wear their aligners, have the treatment, and then enjoy the social media life or even the social life. And they took less painkillers. That's what they're seeing now. Okay? So if you say, okay, for me as a aligner, if I'm going to use an aligner package, my preferred package is Invisalign. I'm not selling you this, but I've been using it for over 10 years now. So they have a lot of packages in the market now, but if you're going to use it for for a child or a patient that is age 6 to 12, they're still having their mixed dentition, you could choose. They have a package called for child, phase 1 for children, Invisalign first. And there's actually not much difference to the material, but the movements are different, the features are different. So if you use you can't use an adult package, you put it in a child, it's okay. But now with the Invisalign first, they have special features that will help to make the treatment, the movements more predictable, and the wearing of the aligners more comfortable for the patient. Okay? But okay, then you say, okay, I have a patient here, I want to do Invisalign, he's 5 years old. Can he start Invisalign? Yes, you can start Invisalign. But if you use Invisalign first, they will prefer that the patient has certain criteria to start the Invisalign first, okay? And which is, they should have first permanent molars erupted and the incisors, 2 of them. At least 2/3 should be erupted, okay? Secondly, you should have some deciduous teeth there. What they're saying, you should have at least 2 deciduous teeth or unerupted teeth in 3 quadrants if you're doing double jaw. Or maybe in 2 quadrants if you're doing only single jaw, okay? So they have certain criteria. I understand that, because you can put an Invisalign first in a 3-year-old, but sometimes it doesn't fit well because the aligners is loose. So what can you do then with Invisalign first? Well, there are some certain things that I think Invisalign first will help. And one of them is it will develop the arch, okay? It will slowly make the arch from this into a very rounded arch. That's what it does very well. That does slowly. I can maintain the space for the developing dentition by maybe opening up the space. Sometimes the children come in, they don't like their teeth. They look like they're very crowded. They can make it look straighter. If you have some spacing or some crowding, it will help you to close any of the spacing that they have, or that is crowding, that will help to relieve it. You can do AP correction. AP correction meaning maybe a class 2 or a class 2 or class 3 correction. You can treat tooth protrusions, and then finally, if you have occlusal interferences, functional interferences, you can have those corrected. This is the range of Invisalign treatment, or the range of treatment that can be done in Invisalign first. You can't imagine such a small appliance, you can do it. So people will ask me, well, Ronnie, what's your preferences? How do you set it up? Because after you've seen the cases, and they're going to come back to me and ask, how did you set up your case? So through the use of and trial and error, I've come to certain preferences. And one of them is I don't expand the first molar, the permanent molar. Don't try to make them wide. They don't do that. You can't do it with the appliance. We have to be realistic here. Okay? If you want to do an expansion in the molars, do an RME, an RPE, or an MSE. Don't do Invisalign first. They won't track. But what I do with the Invisalign first, I rotate the molars outwards. Okay? That's what I do. I rotate it. I don't expand it. For the deciduous molars, what I do is to expand it. Okay? I tip them outwards. That's how I do, because they're very good. Invisalign is very good in tipping. That's the mechanics. The center of resistance will do very quickly. If you try to do an expansion like that, it will off track. So that's how you look at it. If you look at the figures, you can see that I don't do any translation in the molars. If you look at it, you don't see any translation. You only see rotation. Okay? And then you can see there's tipping in the buccal segments of the deciduous molars and canine. So what about the lower teeth? I just tip them out. I don't bother to move them. Just look at your kidney check and see whether you have this tip. It's good enough. You only need 1 to 2 millimeter. If you need more than that, well, the case is not suited for Invisalign. You have so much crowding, so severe crowding, don't use Invisalign first. We have to think. We are orthodontists. We are doctors. We should think if the case is suitable. If you have a case that is suitable, the amount of crowding is mild to moderate, you can use it for tipping, right? So that's what you see. You see the molars, the first molars, I'm not doing bodily movement. I'm just tipping the lower deciduous molars a bit outwards. So I don't do IPR in children. I don't leave spaces after I have them aligned. Why is it that I don't do IPR? You see, there's a lot of crowding, you should do IPR. Well, because I'm dealing with a case in mixed dentition, meaning that there is baby tooth, there are deciduous tooth that need to be there in order to preserve the leeway space. You need to have the leeway space for the permanent molar, premolars to come out. And if you do the IPR, you lose everything. So that's why I don't avoid IPR in children. I don't do it in my Invisalign first. And then the other thing I don't do is I don't create extra space. Because if I have the deciduous molars there, the leeway space is there, I don't need to keep extra space for the alignment of the canines if they come out. So this is the case before, and after I got them aligned, you can see that I rotated the permanent molars, I tipped the lower deciduous molars outwards, and I aligned it, but I didn't open up extra space. I don't need it, because if I calculate from my space analysis that there is enough space, meaning that the leeway space needs to be present, then I don't need to expand it. Because sometimes if you get a clean check from the Invisalign technician, you see a lot of spaces, it's too much. And then, because Invisalign, they have optimized attachment, I keep them because they're very small. They're enough to hold the case. You don't need to replace them. I put in, if I see there's movement, extrusive movement on the incisors, I will put some attachments just to make sure that the aligners fit well. I don't put attachment on the canines if they're very about to exfoliate, because if you put attachment on the canines and they will fall out in 3 months to 6 months, it's going to hurt the patient when she's wearing it. Because the attachment is trying to, every time you take it out, the tooth will get wobbly and the patient will, experience a lot of pain, and he or she will not wear the aligners. So for attachment on canines, I try to avoid it if I know that the tooth is about to fall out. And then I start my attachment on stage 2 onwards. Why? Because I want the child to experience the aligner first, to know how to handle the appliance. If you put attachment on the first visit and you tell the patient to put it on, it's going to hurt the patient. And he's not going to wear it. So I tell them to enjoy the first set of aligners, let them get used to it, to manage it, to take it out. And then on my second visit, they come in and I start to work. So I do it step by step, let them get used to it. So, sorry, I go back again one more. Yes, here. So you can see there are no attachment on the canines. I put some attachment on the incisors too. And there's one more thing that you may already be doing, which is if you have a crossbite, try to see if the case or the bite can close in a premature contact. If you have crossbite on the front teeth, ask the patient or you have to check whether the incisors are able to contact each other when they meet on the first time, when they close. Because that is very important for us as to correct the bite. Okay, this is called a COCR discrepancy. So, the first thing you have to do is make sure that you diagnose the case. Make sure that you see there's a COCR discrepancy. Secondly, take the photos in CR. CR meaning the premature contact. I also take it in the CO, which is the full posterior contact. And then scan your case in both CO and CR. Okay, but the CR position is very important. You need to scan it. You can scan it. The Invisalign, I don't know how, I mean, many of you may be using a scanner like the iTero scanner. You can scan it in CR. So what you do, you just scan the patient in CO, you submit it, and then you do another submission RX, and then you can do the CR scan again in the same visit. So I have 2 scans, one with CO, one in CR. And then when I submit the case to the technician in Invisalign, I submit the CR scan and I submit the CR photo, because the technician will set up the case in CR. Make sure you do it, because CO is a surgical case. Because the patient is biting right in front, could be biting all the way here. It's impossible to treat. But CR, you can treat it, all right? And then you plan your clean checks, everything in the CR position that you've done. And then you ask the technician to give you a bite jump, okay, at the end. Because you have to make sure that all the corrections you have done, that it will fit into place, okay? So if you look at the first slide, you will see that I submitted the case in CR, and then I finished aligning all the case in also in CR to stage 26, okay? And then on twist 27, there's a bite jump, okay? This is the way the clean check works. We correct everything in CR, we go to the last one, you tell the technician, give me a jump. It doesn't matter how you do the jump, just give me a jump so that I get a good bite and I know whether the correction will work. Okay? Remember to do that, because then you will be able to to plan your cases that are in crossbar. Okay, then we'll go straight ahead now. We'll share cases with you, the variety of cases that can be done. There's so many cases that I wanted to show you, but because of the time that I've been given, I'll only show you a few just to show you the versatility of the Invisalign system. Okay, we're looking at an 8-year-old. She's coming. She's very cheerful, but the only thing is that Dad is telling me my daughter is afraid to show her teeth. But you can see it, you know, she's very cheerful, but she's afraid that people will bully her or even laugh at her because her teeth aren't straight. And you know, she likes to sing, she likes to dance, but she can't smile. She doesn't want to smile. So you look at a very early mixed dentition case, age 7, the lateral incisors haven't come out, the upper arch is still very narrow, a bit constricted, and in the lower arch, you see that, you know, there's a certain amount of crowding in the lower incisors. Okay, we see this all the time, and then, you know, we could say, well, what we're going to do then? Are we going to ask the patient, you know, one way of saying, well, maybe you wait till your age 12. Okay, come back in age 12 because I think we're going to treat you afterwards because, you know, by that time you've got all your teeth, we can do it. Yes, you can. You can tell the patient, please go home, come back every year, I'll see how you're doing, you know, then age 12 we do a second phase. We'll start treatment. But then the parent says, my girl, how is she going to face her schoolmates for the next 5 years? You know, she's got this teeth here, she doesn't want to smile. How it may affect her, I may not, but if it's going to affect her, it's going to affect her quite a lot because she's going to be psychologically affected. She's not going to be, you know, outward going. She'll be very afraid. So then the parents say, we're not going to treat her, I'm going to go next door. Maybe he's going to treat her. So, well, then I say, okay, let's see what we can do with the Invisalign. It's not many teeth to do, but it fits into the Invisalign first. So here, you can see we're expanding the lower arch. You see we're expanding the buccal segment. And the upper as well, I'm rounding it off. Okay? So it's only 21 stages, very quickly. Okay, how much is 28 stages? For my cases, in children, I do 7 days per stage, okay? If the patient is not very cooperative, well, then I do 10 days. But I try to do 7. Then, if you look at 21, you divide that by 4, you get 5 months of treatment. Let's see. Oh, we're even quicker than that. We did 4 months, and we got the teeth to straighten out. But then you say, well, the lateral incisors are coming out. That's the reason why I actually finished early, because it wasn't fitting too well. So what I did by then was to do a second stage. I can do a refund, we call it additional aligners. We scan the patient again, we take the photos, we do any assessment that we need, or caries control, cleaning, she needs a bit of cleaning. Okay. And then I did another 6 months. This time a bit longer, because I wanted the lateral incisors to fit into it. Just imagine, this is very simple. The patient was just able to continue with her daily schedule. It wasn't interfering with school. She just had to come in every 4 to 6 weeks. She was wearing aligners very well. And you can see how nice we could get the arch to form. I didn't leave any extra space because I know there should be enough space for the leeway space for the eruption of the premolars later. But you can see that we can actually, in around 10 months, we can have it done. So here you can see the teeth being well aligned, all the improved parallelism. Well, if I can do this in 11 months, well, it's very happy. The child is very happy now. She's able to smile because her smile improved. Her oral hygiene also improved because once they get the teeth to show well, I told her, you better brush back better because now your teeth are straight. You're smiling most of the time. And if you do that, people are going to look at you more, so you better make sure that your teeth are clean. So that's the way of actually motivating patients to improve their oral hygiene. Okay? So, show you another case. Well, you can actually imagine what he likes most. Okay, sweets. Okay, so he comes in. His parents. The reason why they're coming in is because they're saying one of my lower incisors feel loose. Yes, the 3-1, the lower left central incisors is quite placed outwards. And you can see the amount of crown that is showing. You can see the shape of the root. And the reason you can imagine is actually there's a traumatic bite between the upper central incisors and the lower central incisors, and it's causing the lower incisors to actually be pushed out if the patient is biting, he's eating food. So if you look at him, his lower arch is a bit narrow, a bit constricted. His upper arch is also not very well formed. Here again, you can see I'm not doing any movement in the permanent first molars. I'm just rotating them outwards. I'm expanding the buccal segments of the deciduous molars, and then I'm forming the lower. When I expanded the lower, I can bring in the lower incisors to align them, and also to reduce the protrusion of them, so that I can correct the upper incisors better. And then you see, what's this? End of treatment. Yes, we finished them in one stage. Okay? No refinement, just 7 months, one set of aligners, because the patient was very motivated. The parents were very motivated. They wanted improvement. They were very concerned that the lower incisors are going to drop off. So they knew they had to wear it, and the reason why they were so good at it, they told me later, is because I showed them the clean check. Just now you saw the clean check. I showed them, if you're good in wearing it, if you're following the clean check, your teeth are going to follow it. And they took all my words to heart, and they wore the aligners all the time. It's not them, it's actually the patient. Wore the aligners all the time, making sure that the teeth are tracking everything. So he finished in 7 months. So what do I do now? The teeth are straight. Do I just leave it alone? No, I put in Hawley retainers. You can put any type of retainers, but for me, I use Hawley retainers. They're very sturdy, but then you will ask me, why don't you use vacuum form retainers? Because I feel that vacuum form retainers, because the teeth are falling out, dropping out, we've got change in the dentition, sometimes they don't fit well, they're not so good. But I have a special design of a Hawley where it maintains the leeway space between the molars and the incisors. Then everything is there, the teeth don't move, and I tell the patient and the parents, if you are good in wearing your retainers, maybe this is the only time you are going to do orthodontic treatment. Just imagine, a child can finish orthodontic treatment at the age of 9. It is possible, because we're now able to use the appliance to align the teeth, to get them corrected, and if they wear the aligners well, the retainers well, you will see that teeth can be maintained. So 7 months of treatment, we're done. And the good thing about this case is that he started referring all his classmates to come, because his mom was very happy. And she went out and said, look at my son, he finished treatment. And they started coming in. He referred his cousins to me, 2 already, and then his classmates. So this is a way of actually marketing ourselves. You know, you do one good treatment, you make sure they go well, they're very comfortable, and they start coming in. I think that's what we want. We need to take care of patient on one hand, but we also need to make a living for ourselves. And this is a very good way of actually being altruistic, meaning I enjoy, I get enjoyment from my work. Okay, then we go more difficult now. Okay, so we see a lot of these cases. They come in, reverse bite. This is very difficult. You look at it, oh my gosh, this is very difficult. Well, you look at the case carefully. Yes, there's a reverse bite, a deep bite too. There's a bit of crowding, but the arch shape is a bit constricted. And then the upper arch, you can see, is not well formed. It doesn't have this Roman arch form. It's just squarish. That means you still have ways to improve it. And the parents happens to be an Invisalign, the providers in Hong Kong. She was in the Invisalign company, and he came in, brought his son, and said, "I'm confident you can treat him." I said, No, let's look at him first, because he's very difficult. It's not so easy. Okay? So here he's still in mixed dentition. So just now I mentioned, if you see a crossbite, check whether you see a COCR discrepancy. Okay? So I immediately, when there is crossbite, I ask for, can you bite on your front teeth? If they can bite on the front teeth, yes, then you have a chance. Okay? You have a chance of treating them because you just tip the incisors forward or you move the lower incisors backward, then you're already in safe water. Alright? And then there are other ways of actually trying to get there. But at least you should do this. And then just now I mentioned, take a photo in CR, scan it in CR, submit it in CR, set it up in CR, and then ask for a jump. So that's how you see it. I submit it in CR, I treat the upper arch and the lower arch separately, and then there's a bite jump at the end. Okay? Just go slowly, then you can see a jump. That's what you look at. You don't see it in live, but you should ask for it. Now the bite, you can actually see it like continuous, but I just want you to see how it is if it is a jump. So you can see I put attachment on the incisors because we're going to move this. I want to make sure that the liner are fitting well. So, but then you can't expect the plastic to do all the work. You need help from the patient. And one way of doing it is to wear elastics. Yes, children can wear elastics. You have to tell them what's the reason of wearing elastic. And is it difficult? No. Okay? I only show them once in the office. If they're in the clinic, I put buttons on, there are hooks on the first molar, the upper molars, and on the lower canine, I have these precision cuts. If you know the Invisalign term, it's a hook in the plastic. And then I teach the patient to hook the elastics. And you may ask, is it very difficult, to teach them? No, because I tell the children, I show you once, you go home and do it. Don't let them do it in the office. The parents will tell me, can you try in the office? I said, no, don't do it. Go home. I show him once, you go home and do it. Why? Because I give him the confidence to do it. All the children, they come in, I teach them to wear elastic. I show them once where they have to put the elastic. I show them how to hold the elastic, hook it up to the front. I show you on both sides. And I said, go home, do it. Don't stay in the office. Because if you stay in the office, you have maybe 5 pairs of eyes looking at you. How are we going to do it? I'm going to get scared, man. So I don't do it. I tell them, go home, try it at home, and that's it. And next time they come in, all the elastics are still there. That's it. I've never experienced problems with patients trying to wear elastic. I give them confidence. You know, I give them control, because children nowadays need control of their lives. We cannot micromanage them. We need them to have control. If we give them the confidence to do it, they will do it. Just do it. We cannot be tiger moms or tiger dads. We have to let them live their lives. And the only way they can do it is to let them do it by themselves. Yes, you can do it. I look them straight in the eyes, you go and do it. But at home, don't do it here. Okay? After 11 months, we jumped the bike. Okay? So, well, it still doesn't look quite nicely because the bike is still open. So we went another, he was wearing quite well. Look at 48 stages, he was very good at it. Because he's seeing changes. His face was changing. So this is the occlusal. You see, we formed the arch. And then I did another additional one for another 6 months, 16 stages. Why did it take so long? Because I slowed it down. I slowed down the aligners so that he can wear the elastics. I want him to continue. We can control the timing. If we wanted to go quicker, then we change quicker. If we want to go slower because we want more elastic wear, we make it go slower. I say 10 days, like 2 weeks. You do it. So it's stretching it. So we have more aligners to wear. So this is at the end of aligners. So initial, final. So you say, oh, it's not yet finished. Yes, it's not yet finished. But the main aim of treatment was actually to correct the crossbite, isn't it? Then I put him on Hawley retainers. So let's look at him then. Then you said, oh, it's gonna, let's see him. Do you have photos of later in life? Is it going to relapse? Well, he went to UK to study, and he came back once a year. And the last time I saw him, was I think last December, he was already like this. He's just wearing his retainers, and his dad asked, can I change the retainers? Yes, we need to, because it's so different now. But I finished the treatment 2 years ago. Just imagine, he wasn't studying, he was still in primary 5 or grade 5, grade 6. I finished his orthodontic treatment at grade 6. He went to study, came back, and now we got this occlusion that is, we don't need to treat it. Would it have been different if I didn't treat him? Yes. I think if we didn't treat him, I think we might have ended up like a surgical case, because there's a functional malocclusion where the jaw is always coming forward, and it may be very difficult to treat. But sometimes if we go in early, we can treat them. But we should always forewarn our patients to tell them, we need you to wear well. We hope that we can get a good result, and we hope that you can grow well. Because sometimes in patients, we will see the mandible coming forward. But it's better not treating them, because at least we gave them a chance to have their bite corrected. So this is one thing that we can't tell patients, because parents will ask us, is it going to be successful? Well, we can only try. But sometimes we see that it's a difficult case to treat, then we can tell them, sorry, I don't think you're treatable. But if you see there's a COCR discrepancy, you can tell them there is a chance, but we need you to wear it well, and we hope you will grow favorably at the end. So then we'll go to the next one. Then you look at it, well, I think for you here, sitting here, you will see, oh, there must be something in between the two teeth. Yes. Okay, he's 7 years old. They were very concerned that he's got this big gap. Actually, they went to a dentist because of this gap, and they found that there was a supernumerary. Okay, there was actually a supernumerary already in between the two incisors. So what they did, they had it taken out. But after they took him out, because it was there for such a long time, the two central incisors couldn't come together. So they referred them to me, and we said, okay, let's see what we can do then. So this is just Invisalign. Didn't change much of the attachment now, and it's very good fitting. You know why? Because the tooth are long standing. You know, long standing. The plastic wraps around every one of them. You don't need attachment. It just wraps around the incisors. So it will go very quickly. So this case here, this is the last slide that I have of it. But it was only 3 months we closed it. They were very happy already. They can see the teeth are closing, and you can see that the upper incisors, the upper left lateral incisors, the tooth is actually being displaced because of the initial position of the central incisors, the tooth germ being displaced palatally. That will need some treatment later. But this is why I'm saying that this is the last stage that I'm seeing, because he's moving to Australia. Okay, well, I can't treat him. But because I'm using Invisalign, I can transfer his case to Australia. That's how I take care of my patients. These are still my patients. I tell them, go and look for a dentist or an orthodontist in your area, in your locality. See if they do Invisalign. If they do Invisalign, let me know. I'll transfer the case to you. I'm taking care of them. I don't abandon my patient mid-treatment because they're leaving me. I want to make sure that they're in good hands. So they went to Australia, they found a dentist, and I told, if you can't find a dentist, I told them, come back to me. I'll ask my local rep in Hong Kong to contact Australia in Sydney to get you one. We'll find a dentist for you. I take care of my patient. I don't make money out of it. That's why they like us. You know, if you say, I take care of you, I'm not trying to make milk money out of you, then they will appreciate, you know, your concern for them. They will wear the aligners well. This is actually, if I told you a story about him, we charged them for a fee for Invisalign. And then the mother came in and said, I cannot pay the rest. I paid half of it. And she said, I couldn't pay. I said, why? Because my in-laws, they're living in Spain. Both of them got cancer. So then she started crying in the office. I said, don't worry, we'll take care of it. I'll leave the rest. You just pay me the down payment that is there. Just leave it. I'll just do, charity. That's what I did for this case. And they were very happy because sometimes in life, we're here to make a living for ourselves. But there are other human beings, they're not in such a good state. They were very well off, but then suddenly because of moving to Australia and then they have to do all the take care of their parents in somewhere else, they run out of money. So for me in this case, I said, well, I won't charge you the rest. Okay? Just leave it. Enjoy, your life. I hope that one day your child will grow up well. That's it. For me, it's not a worry. I'll take care of you. I hope that one day, if you, I don't expect anything in return, but I hope, it will work out well for you. And they were very happy. Till now, she's still WhatsApping me, telling how they're going. Sometimes, we treat patients, but we also are humans. We have other, we take care of people too. So that is what you're looking at. Well, then you see cases like this. They come in, I think you can imagine there is something. Well, he was referred to me by his periodontist, and they found they had 2 extra teeth. It was a class 1. There was a slight amount of constriction, but the space is there, but you needed to create the space for the rotation. He got 2 supernumeraries in the premaxilla, and they had to go. There's no way I can treat the case. You need to remove them. Just Well, the periodontist took care of it. Okay, so what to do then? Well, are we going to wait till he grows older? Yes, you can. Or do we need to take out teeth? Yes, that's another way. You can take out the primary canines, expand it. Or maybe later you can take out more teeth in the posterior region and create a space. But what about now? Can we do something just to, not to make it bad? Because if we don't do anything, what happens is with the eruption of the canines, the space might close. Any space that is present now may close. So what I did was to see if we can expand the space in the anterior region to see if we can rotate it. Okay? So you say, okay, we may have to do quite a lot of biomechanics here, loop mechanics, trying to do it. I said, well, let's see if we can try with Invisalign, with clear aligners. So this is how I did it. Expanding the buccal segments, rotating the molars, the first permanent molars, and then put attachment on the lingual of the upper incisors, attachment on the labial of the incisors, and then we rotated it. Well, let's see if it's possible. If it's not possible, yes, then we'll go in and do refinement till we get it. If not, we'll put braces. So you have choice. It's not the end of the world if clear aligner doesn't work. You can do braces. Okay, but let's see how it is. So he started wearing like, we check, every time the patient comes in, you see the photos that I take, every time they come in, make sure that the aligners, the aligner they're wearing is inside the mouth. Take a photo of it, because then you'll know whether the aligner is fitting. Don't take it with the new aligners. They look cleaner, but it doesn't fit. Take a photo of the present aligners that they're wearing, okay? And then you take photo with the aligners outside the mouth to look at it. But this photo is just to show you, these two photos, to show you the fitting. Because the first thing they come in, I look at if there's any space between the aligner and the teeth. If you don't see it, and the parent's gonna ask, how is the treatment? Is it going well? You can just say, yes, it's going well. How do you know it? Because you didn't take the aligner out, how do you know it? Yes, because the aligners fit well. They're very good fitting. If I take it out, I don't know whether the treatment is going well. Then you will ask me, do I look at the clean check? No. I don't look at the clean check. Because I look at the aligner. The aligner is the clean check. So if it fits well, that means it's following the clean check. I know people, they open all the clean checks. I'm so confused. Because I look at the aligner, you fit it well, yes, good. And also I've been treating Invisalign patients for a long time. I go in with my finger, I remove the aligner myself. Then I can feel it. If I can't take it out, the first thing I'm going to ask the patient, are you wearing the right aligners? First. Secondly, are you wearing aligners? Are you wearing it all time? I mean, are you only wearing it bedtime? So by doing that, I can feel it already because I'm taking out aligners for the last 10 years. I know how an aligner will feel at the end of its life, the stage. So if it comes out easily, then I know the patient is wearing it well. And I also look at the fitting, all the spaces. I go around making sure that the other thing that I look at is the aligner margins to see they don't flare out. Because sometimes they look like they fit well, but they flare out. That means something is wrong. Then you have to be very careful because the roots may not be in the right place. So then I go in, I check the roots, make sure that no, there's no sensitivity. I ask the patient, do you feel sensitive? You drink cold or you bite on it. If it's sensitive, I stop, I redo it because the roots may be hitting the bone. I tell patient, if you feel that when you wear your aligner and it's very sensitive, please come and see me. It's abnormal. It should be 2 days should go away. If it's sensitive, that means something is wrong. You don't want the roots to come up, okay? So in the 2 stages you're seeing, that is very good fitting. Sorry. And then look at it. he was very motivated because his tooth, his central incisors was rotated. He has very good family support. Child was very diligent at school. You know, he was well behaved. He was, you know, they had 3 siblings. He was looking after his younger siblings too. But he was very good. His mom was very looking after him. And I finished the treatment, just 1 set of aligners. You know, 41 stages, no refinement. I didn't need refinement because we set up our cases well. We expand the case, we expand the space for the rotation. I think we can actually achieve it. We use the appropriate numbers of attachment or the placement, the position we place it well. I think we can actually do very good treatment with clear aligners. So we finished in 9 months. I gave him a fixed retainer because he needed a fixed retainer in this case because it's going to rotate. Sometimes we have to think, what was the initial position of the teeth? If they're not in good, if they were rotated, you know, well, you could think of putting a fixed retainer. Are you going to do precision? You know, anything just to remove the transeptal fibers? You could think of it. But for him, I said, no, I'm just going to put a fixed retainer. And the fixed retainer is not the most ideal because I wanted a fixed retainer maybe from the canine to the canine or maybe from premolar to premolar, but because those are still baby tooth, so I put it only from the incisors. But that's how you can manage it to hold it. And for the lower, I gave him a poly retainer. So this is the before and after, and it's working wonderfully. Okay, it's not only case, you can see how it is. You put the right attachment, place attachment where they should be, you can actually get good outcome. Okay, then the next case is, I'm going a bit older now, because, they come in, you know, the parents saying, teeth aren't straight. All right, when you look at it, oh yes, still late mixed dentition, you see a deciduous canine and a deciduous, that's just the only one, the deciduous canine. But it looks a bit strange. Because if you look at it, the upper left permanent canine is more or less 2/3 erupted. And you would expect the contralateral canine on the right side to be more or less erupting. But you don't see it because, you know, Prophet was saying, you know, if you don't see a tooth that is, you know, erupting while the others is being erupting for 6 months, then there should be something. So once you see there's a difference in left and right, yes, then you have to go away. Then if you look very carefully in the 1-4 and 2-4 region, you can see that there's a whitish bulge, submucosy. So that's actually the canine. So here, you can see it. The canine, it's transposed between the 1-4 and the 1-5. Okay? And the 2-3 is still there, it's quite intact, the root is still there. You know, it's gonna maybe last for another 10 years. Okay? Then you take a shaft and you look at it, well, she's a bit protrusive, but it's okay. If you look, because I don't use the shaft to determine the patient focal, I use the shaft to confirm what I see. The incisors, the upper incisors are a bit proclined, the lower incisors are a bit retroclined. They're upright. Okay? So that's what we're seeing in this set. So what are the treatment options? What kind of options do we have in this case? Well, we have a transposed canine. She's in her permanent dentition. The teeth are a bit, the incisors are protrusive. So what are we going to do? What choice do we have then? Well, one choice is just take out the transposed teeth, end of story, no treatment. Tell them, just take out the transposed teeth, you may not do a surgery. Wait 6 months to 9 months, I think it's gonna come out, and then take it out, no treatment, go home, live happily after. Okay? But then later, if the diseased canine falls out, put an implant. That's one option. What about, well, just now I mentioned she's got the permanent incisors are protrusive. Well, she's got crowding because the left side is at half a bit of class 2-ish, not full class 1. The canine doesn't have space to come out, and then you have this transposed canine. Well, one option would be, well, take out the 1-3, the 2-4, and maybe 2 incisors in the bottom. And then you have a full fixed, orthodontic treatment, either with, full braces, take it out. Well, that's option 2. Do you have another option? Okay. What about, can we keep the teeth? Or maybe just take out the diseased canine should go. Yes, can we take out the diseased canine, create the space for the 1-3 to come in, and then treat the class 2 on the left side. So the left side. Okay? Can we do that? Yes, that's one option. You could, what we call, move the teeth, like using headgear, to move it, that's one way, or maybe now they have this distalizer, use the distalizer to move it, or you could use implants to move it back. You have so many options. But what about if I say, can you do it with a clear aligner to do it? Yes. Can we distalize, because the patient is still young, we could maybe distalize on the left side, and then create the space on the right side. Okay, so that's what I did. So I'll show you the clean check. So I took out the diseased canine. I moved the 1-4 forward, but look at the left side. The left side, the teeth are being distalized. Okay, and the patient is wearing elastics on the left side because we need the anchorage on the left side because it should be Newton's first law, not Newton's third law. The system should be in equilibrium. That is Newton's first law. We always get it mixed up. I got it mixed up too. I thought it was third law, it's not third law. It's Newton's first law. We should keep the whole system in equilibrium. And because of distalizing, you got this forward movement, so you need elastics on one side. But be careful when you wear the elastics on the left side because you might do this on the left side. So a lot of biomechanics, okay? You have to know the biomechanics, and if you, just now I saw the advertisement by Professor Choi from Korea. He's very good, okay? He's my hero. So what I did was to expand it. I expanded the space for the canine. And using a clean check, you can actually plan it very well. You can actually see how much expansion you need, but also whether you need further things, like you really need IPR, because sometimes the two sides discrepancy is there. So you can use the clean check to plan the good interdigitation, the good outcome of the case. Because if you don't use a digital setup, you may not be able to plan it so well. But using a digital setup, you can actually plan it till the end. So, in 5 months, let's see. All right, we're now opening the space for the canine to drop in, the 1-3. You can see the premolar is being moved forward. And on the left side, I'm distalizing the upper posterior teeth. I use elastics to hold on to to preserve the anchorage, because if I don't use elastics on the left side, if I start to distalize, what will happen? All the front teeth may move forward because of the law of equilibrium, because they're going to move forward. So I need elastics on one side to put it, and on the other side I don't need anything because the aligner, the plastic, is actually, squeezing in between the two teeth and to move it. Okay? And then you can see the primary set. In 9 months we finished the first set, and the canine is dropping in. Now we have to pick it up. I don't need to have something there. The aligner doesn't need to cover it. Now the aligner is actually getting in the way. It's actually preventing the canine, the 1-3 from coming in. So this is the end, 10 months, it doesn't fit well yet, then we have to go for the second stage. The bite is still a bit off, but this is just the primary set. Okay, the canine is coming in nicely, the roots are parallel, all the teeth are still in good shape. So I go for an additional set, and you can see that I put an attachment on the 1-3. There's a slight light attachment, and the aligners is just helping to pull it down. Why? Because the canine has space, and it's trying to come out by itself. When you put it in, it will come out. Okay, and it will. The aligner stages are, in sync with the eruption speed of the tooth. Okay. But you can see the bite isn't quite well yet. So what I do then is to, bond buttons. All right. I think you see people do buttons. I didn't know why they could have such good finish. I went to courses. People show me before and after. Before and after. Nobody showed me the middle part. I go in. I see. All the big speakers. I went to many aligners symposium, Invisalign symposium. I see before and after, but I don't see the middle. Until one day, I saw Dr. Samoto. He put this. I go to people's courses. I'm actually a spy. I try to get, hints from them. But you don't need to be a spy today. I give you everything. So Dr. Samoto, he did this. I said, oh, no wonder. I saw. He did all this to get the teeth to suck in. So what I do is to cut the aligners, bond buttons, and have the patient wear the aligners and to suck in the occlusion. And I also have the cross elastics because her midline is off, so we're trying to get everything on. So 4 months, 5 months, finito, finish. Okay? We get the canines to come in. Well, it's not going to affect the bite. Okay? And even if it's affect the bite, well, what can we do? Am I going to do heroic orthodontics by moving the canine to that side? Yes, I've seen people do it, but is it worth it? Well, it's up to us to decide. Decide on the case. If it is suitable, you can do it. But in this case, I don't think it will work. I may kill the tooth. So in between is okay. She keeps all the teeth. And you can see the result. That side, we were able to get a good bite. This side, the left side, I was able to get a good class 1 bite out of it. Right? So here we see it. The roots are okay. And we look at the comparison between the x-rays. You can see that, we actually improved the incisors. If you look at the upper incisor to ascend, we actually were able to upright it a bit. But it's not too much, but it's okay. It's good for a full file. All right? For the lower incisors, you could see we actually kept it. Even with all the elastics we were wearing, everything is kept where it was. We didn't procline it too much. We did a little amount of IPR, and she had some amount of growth to help. That's the good thing of treating growing patients. They help you. They help us to mask our deficiency in our treatment. So sometimes it helps if there's some growth. So this is before and after. You can see that, the incisors, they were quite alright. And just a bit of hint for all of you that are doing orthodontic treatment, including myself, if you just get if you do a finish, and you see a good case, remember to clean the case. I mean cleaning, meaning polish it well, remove all the stains, get the patient in good oral hygiene. Because you may not know, one of you may one day be on this stage. You may come in and show me a case, and we look at it, yes, so nice, it's so clean. I've learned this from the years that I've been to orthodontic symposium. You see cases that are nice presented because they're very clean oral hygiene. And you see other cases, they're very good finish, but the oral hygiene is really bad. It's bleeding all the way, a lot of staining. This is just a few tricks that you can do just to improve the quality of your finish. And it will help in actually communicating to your patient that you represent quality orthodontic care in your locality, in your practice. So make sure that you can achieve it. I did all the cases that I finished is actually, I do all the cleaning myself. I make sure that everything is clean. I take all the photos myself. I know people have people to do it, but you can do it. If you train your staff to do it, they can achieve very good outcome for you. Because you may need to take the case and show it to another patient to show the quality that you can give them. And if you have clean cases, the eye can only see clean things. They only see symmetrical things. And they will immediately in the back of their head tell themselves that you are a very good clinician. So this is a hint that I can tell you. I've done it many years, I see it in the patient. You see, give them a good case, they will say, yes, I'm going to do treatment, right? And then, this is my last case. Well, they asked me to give me some crowded case, even an extraction. To tell you the truth, I don't do many Invisalign or clear aligners extraction cases. I've done a lot, I've done many in the past, but nowadays I'm starting to do more aligners with specific cases. But I just want to see if we do Invisalign aligners, what kind of treatment can we get out of it? Well, this is a very severe upper arch crowded. There's also crowding in the lower arch. But the incisors look very upright. Well, the X-ray showed there's also crowding in the posterior segments, in the third molar area. Okay? And the shaft that we're looking at, well, the basal bones are in good relationship, but the thing that you're looking at, well, the incisors are upright. We're not looking at proclined incisors. This makes it quite a challenging case, because if you treat a case that is very proclined, very protrusive, the teeth are proclined, and there's crowding, it's very easy to treat it with any appliance. With fixed appliance, you put in a nickel titanium, it will just go back. With Invisalign or clear aligners, you retract it. It's like magic. But the cases that are difficult to treat are the cases where the incisors are upright and you need to take out teeth, you end up with a lot of spaces that need to be closed. This is where we have to be careful in managing the cases. Well, what are your treatment options? Well, you have to give yourself treatment options because sometimes it will let you think which is the best for the patient. Well, one treatment option, well, can we extract the instanding lateral incisors? Just take it out, end of story, please go home, you're done. No need for treatment. Well, she's very clean. Well, she can accept the irregularities. Well, then she said, no, I come in because my teeth are not straight. All right. What about taking out only the lateral incisors and then do full mouth IPR? Interproximal reduction. Can you do it? Well, it may be a bit challenging in the lower. The upper is also challenging. But what about maybe distalizing? Just now I mentioned about distalizing. Yes, you could do it maybe on the upper right side. But in the left, well, we have some difficulty trying to distalize. Well, maybe take out the lower third molar and then distalize, but you have to do surgery. Okay, sometimes I look at a case, I can come up with maybe 5 or 6 options. And then what about, okay, it's too complicated, too many surgeries, involves too much surgery, I need to take out third molars, okay, and I still do a lot of work. Okay, what about taking out first premolars. Okay? Well, this side, on the right side, I'll take out the first, maybe the upper first, the lower second premolar, and then on the left side, I take out the first premolars, and then I move the canine back, and I move the lateral incisors up. That's another option. It's already 4 already. Just imagine, I'm just standing here, I can talk to you, and I'm already 4 to 5. But what about if I want to do it simple? I don't want to be a hero. What can I do then? I also take out teeth, but I'm gonna be more simple. Okay? What about if I take out the lateral incisor because it's already displaced, the root is displaced palatally, and I take out an upper 1/4, the upper right first premolar, and on the left side, I take out only the I only take out the upper left. So I only take out 3 teeth. Okay? But then, what's the advantage of this? Well, the advantage is that it's reasonable, meaning that the time is short, because I don't need to move teeth on the left side already, because it's already aligned. And secondly, it's logical too, because just imagine, we take out a healthy tooth, which is the 2-4, you move the canine there, you move it's more or less the same thing. Because I went to many years ago, in 2009, I went to Taiwan to hear the last lecture that Vincent Cockage. Have you heard of Dr. Vincent Cockage from Seattle, from Washington? He's a very good orthodontist. You look at his case, a really nice finish. And he's a very good teacher. I only went there, I came back with 2 things. And I remember it till this day. He told us, or he told the audience, our treatment should be logical. You don't take out a tooth and then you move another tooth that's the same size into it. It's not logical. And the second thing he told us, our treatment should be reasonable. Sometimes you see cases, in symposium. They treat it very well, and then you ask them, how long did you treat it? For 5 years. Is it reasonable? If you give me 5 years, I can do your case. You have to be reasonable in your treatment planning, logical. You take out a good tooth and you put a bad tooth into it, or you move a very displaced tooth into it. It doesn't make sense. That's why I plan all my cases with these 2 things in mind. I want to make sure that my treatment is short enough to be able to achieve the outcome, and it should be logical enough that I don't do something and then people look at it, it's what you do. I don't see any difference in what you're doing. So just remember this. It's not my motto. It's just Vincent Cocker. She told me that, and I just remembered the 2 things. I flew all the way to Taiwan, and I just remembered those 2 things, and it's been with me for the last 10 or 15 years for me. I remember all that, and it helped me in actually doing my planning. I don't do heroic dentistry, heroic orthodontics. People do a lot of crazy treatment plan just to be a hero. Heroes are not made, they're accidental. Have you seen the movie Accidental Hero? You don't become a hero, you just, you have to happen by accident, and they say he's a hero. Okay? So just remember that. So that's what I did. I took out the lateral incisor, took out the canine, I took out the first premolar on one side, and on the other side I didn't need to because the molars was already in class 2 on the left side. Okay? So then you have to discuss with the patient this plan. This plan doesn't have, it's a free plan, it's so easy, it's so smooth. No. Before you do this plan, discuss it with the patient, because she will need further management after your orthodontic treatment, which is how do we manage the upper left canine. Okay? We did an easy setup, but you have to discuss with the patient. She will need further management of the canine. Okay? So here, we'll go back. So in progress, 7 months, do extraction. Remember to put the elastics on, just to hold it. The stains that you see is actually from the patient taking medicine, herbal tea. Okay. Put elastics on, make sure that it's well controlled. But you can see that actually we're putting everything back. It's actually on one side the midlines is starting to correct, and also the overcheck is actually starting to be reduced, but because she's wearing elastics too well, right? And then when I came at the end of this first set, you could see that the roots are still parallel, okay? Because I did it with the Invisalign first premolar protocol that they had at that time. I used a small elastic, but you can see that it works. And one of the reasons that it works well is because the patient is wearing it well. If the patient are wearing the aligners well, the aligners will usually track, right? Here, you can see that the canine that I moved is all the roots are still in parallel. And then I went to additional aligners. You could see that I started because of I did some IPR, and I put in elastics for them. Here you can see it's on one side only. On that side, I didn't do anything yet. But you can see that there was some tipping on the forceps, so I used some elastics to try to see if I can improve it. Then I finished the second set, 6 months. I used 6 months to treat it, and you can see it's already starting to look nice already. All right, this is just with Invisalign, and also the buttons. I didn't put braces on. And then the second set of aligners I went in is just to finish it off, to see if I can get better bite control. Because sometimes if you do a second set or a third set, what happens? The bite opens up again. Then I put in these buttons and I started, patient wearing the buttons. If you look very carefully, the buttons are like a sling. I don't use like triangular elastics. Don't use triangular elastics or these rectangular elastics. They will rotate your teeth. They will rotate the teeth. You use a sling. You see the way I do it is not to use, this triangle. They're all in a sling. So I use very long elastic. Make sure that they're light size. Then you could use a sling. Then you can connect all the teeth together to try and suck in the bite into the aligner. So this is the end of treatment. Teeth, all the extraction space is closed. The teeth, the upper incisors are still upright. We closed all the posterior spaces. And the space on the left side, you could argue it's not closing too well, or it's not closed interstitially well, because there's a two-side discrepancy, because it's not a lateral incisor that we're looking at. So here you can see the root inclination, root parallel. Well, the upper incisor is slightly retroclined, but not too much, okay? Not too much. So the upper a bit too, because you expect that to happen, because you have a bit of extraction. But you look at it, the profile is still very good. We didn't bring it back. So the final treatment time is 17 months. The treatment time is reasonable. Okay? It may not be logical to some of you, because you say, no, I want a lateral incisor. It doesn't look too well. That's why I was saying, you need to talk to the patient, because you're going to do the next thing, which is to build up the composite on the tooth ring. you can't do it, you can pass the case. I pass the case to my colleague and tell them to remove the buccal bulge of the canine, to build up, they may have to trim the custom and then build it up with composite. I mean, we can do very good composite build-up. And we didn't do any gingivectomy yet because the patient is still growing. We're not going to touch the gingiva at this time. And if you want a good article on how to substitute the canine for lateral incisor, you can look at it. This Sackerson, he's very good at it. You just go to the AGO. They have a good article on how to choose your cases, to manage missing lateral incisors with substitution of the canines. Okay. So, this brings me to the end of my presentation. I'm glad that I'm still within the time frame that's been given to me. And I just want to, remind the audience here, because I know you are all doing clear aligner treatment, okay? But just really know that if you do clear aligners, in a growing patient, well, for me as an Invisalign provider, I see that the advantage is that the Invisalign system can treat a very wide range of cases, but also multiple problems at the same time, okay? And the other benefit that I see is it's a good practice builder for your practice, because they know that you're good in traditional type of orthodontic treatment, but you're also good in Invisalign, because you have to be good. We cannot live in a hermit kingdom. We have to be able to be versatile in our appliance. And having Invisalign, because it will, nowadays with all the social media that there is, patient will, once they're enjoying their journey, their orthodontic journey, they will market your practice. They will market you as a doctor, as a fine, doctor taking care of their patient. The other thing that we're seeing with aligners now, because everything is now digitally set up, and all the cases that I do, everything is digital. Photos, taking the records, the digital scan for the models, the X-rays, everything is digital. And having a scanner in the office is actually a big advantage, because children or even adults are very afraid of having molds taken. The reason why I'm able to, treat very young children is because I do a scan on them. Once you do a scan, then they will play with the scan. It's actually a practice seller. They sell their practice. They go away and say, oh, that practice is very good. They don't take molds. I'm afraid of it. I might gag, I might choke, if I do molds. But having, digital is no good. And the last thing for me as a clinician, because I take care of patients, I look after my patient, is that I can reduce the complications that I see in children that are growing up with orthodontic problems, with a malocclusion. And my ultimate aim when I treat growing children is that I aim to fully correct their bite. Because that's very important in setting up our cases. And we aim to set up a case so that it will progress to a phase 2, we have failed. Because we have failed ourselves, we have failed our patient. Because we need to take care of them. Even though we're here in this world to earn a living, but we as doctors, we've been given that responsibility to take care of our patient. That's why we need to take good care of them. Because I treat each case, each patient, as if it is my own daughter or my own son. Then I will treat them well. So I hope that that we can do this so that it will help. And having having an appliance or a system that can help me achieve that, I think I'm very fortunate now that I'm living in this 21st century where there's digital, there's many type of appliances, clear aligners to help me do that. Thank you.